Today's topic is rapid evidence reviews with the peer team. That includes Tina Kronik, Mike Colber, Adrian Lindblad, James McCormick, and myself. There's lots more. Unfortunately, Nick Dugray, who was to join us from Montreal, an important part of the peer team, he couldn't make it today due to other commitments. But we will press on without him, and I think I might be able to cover his topics. So Brian, if we can move to the Jeopardy board. So guys, this is what you'll be seeing frequently today, and we'll be asking you to pick from this board of what you'd like us to cover. So you can see there are 10 topics. I will ask certain groups to choose which we're going to cover. And I'll ask you to pick by number, please. It's just a lot easier for us to sort through if it's by number. And we'll come back to it multiple times, so you don't have to memorize it by any stretch now. If you're watching us via YouTube, you're watching via YouTube or Facebook, but if you're watching via YouTube, you can make comments and put your vote-ins on the right-hand side. If you can't see the comment section right now, that means you're in full screen mode. If you're on YouTube, you just put it in the comments section. And we'll come back to this in a few minutes, but you can already start thinking about what you would like to vote for. And our first region to vote will be Ontario. Brian, can we go to the next slide? We of course have to do our disclosures, and that's very important. And so it also gives us a chance to introduce the speakers. And we'll start with Dr. Tina Kronik, who I've known for a long time, was one of the three of us who started it with Mike Colber and I, started the peer group. And Tina is now the director. Tina, would you like to introduce yourself and just comment on your disclosures?
Oh, sure. Great. Good afternoon. My name is Tina Kronik. I am, as Mike said, the director of peer. I am a family physician and the co-director for evidence and CPD with the Alberta College of Family Physicians. So I don't have any financial conflict. I have some non-industry funding, and I've received honoraria from the ACFP for talks I've given.
Great. And Mike Colber, as I mentioned already, joined us very early on in forming the peer group together, even way before we called ourselves the peer group. Mike, do you want to introduce yourself and just address your disclosures as well?
Sure. Hello, everybody. Mike Colber, family physician, Peace River, Alberta, and proud member of the peer team. My conflicts that we've received honoraria from not-for-profit people, including Best Science Medicine courses, Alberta College, BC College, that kind of work. I've also co-founded a company, university company that looks at the quality of primarily colonoscopies in healthcare professionals, but doesn't have anything to do with what we're talking about today.
Great. And we talked about when people joined. About 3 years after we all started, Adrian joined. So she's been around working with us for almost a decade, I think. Adrian, would you like to introduce yourself and talk about your conflicts?
Sure. So I'm Adrian Lindblad. I'm the Knowledge Translation and Evidence Coordinator for the Alberta College of Family Physicians. So I'm a paid employee by them. Otherwise, I don't have any other conflicts with any drug companies or anything like that. I don't have any spin-off companies like Mike or anything.
Next slide, please, Brian. And last but not least, James McCormick. James has been working with all of us for a long time and actually was one of the pushes, I think, for many of us to get into this kind of work. Not that you're that old, James. We're not trying to imply that, buddy.
Well, the answer, I am. So there you go. No conflicts of interest. I work with the Faculty of Pharmaceutical Sciences at the University of British Columbia. Many of you might know that Mike and I do a podcast, and we have a premium subscription model for that. So we get some funding from that. And about 37 years ago, I went to Paradise Island because it's an ACE inhibitor company. But other than that, I have no conflicts.
That is an awesome confession, though. That is absolutely awesome. I went to Paradise Island because it turns out I've never been to Paradise.
Sounds fun.
So I'm Mike Allen. I'm, as I mentioned, a family doctor, and I work for the College of Family Physicians of Canada. I also am finishing up some work with the University of Alberta, and I locum here on the island where I live, Salt Spring Island. I've taken funding from a variety of sources like the Alberta College and CHR and for grants and honorarium for speaking. And we all are involved in 2 RCTs, but everything is publicly funded. I didn't get to go to Paradise Island, but I did do a drug dinner 22 years ago. So, Brian, do you want to move on to the next slide for us? We just want to remind everyone that this is a certified program, and you can claim MainPro credits. Just by following along in the chat window, you'll see links for that. If you complete the link by Sunday, you will be able to claim credits. So we do encourage you to do that. It's worth 1 credit, and it's a direct entry credit, so it takes a little bit of the work from your side. Next slide, please, Brian. We just have to quickly review our learning objectives, and they're quite straightforward. We are going to look at the best available evidence for diagnosis, for treatment, and for prevention. And how do we prevent transmission? So pretty straightforward learning objectives, and it'll all depend on what you guys pick. So let's move to the Jeopardy board. Great. And so we'll have Ontario, people from Ontario just vote in what they would like us to cover, and then we will transfer to whichever speaker is going to cover that section for us. We have, where can you find these? We will provide you a summary at the very end that allows you to look at these, the bottom lines of these, because most of them are tools for practice, and if they're not published now, they will be within the next week or two. But if you're really anxious to see the bottom lines, they're also available. They'll be available on our CFPC webinar page. Just waiting for feedback from the team to tell me which one you're voting for. Don't forget to use the numbers to vote, and we'll definitely address the question. So I'm Google Docs is slower than we thought. That's the lesson learned for today. Early votes for 1, 4. So, oh my goodness, of course, there's lots. Why don't we go for number 4, PCR testing? So I think that's Tina. Why don't you start us off with PCR testing?
Okay, sure. Yeah, thanks, Mike. I will go ahead. Yeah, I'm sorry this was the first one chosen. We could talk for an hour on this, but I promised Mike I'd keep it 3 to 5 minutes. Question around how sensitive and specific is the PCR test. So a bit of background. So the standard is the PCR test in Canada, and generally that's looking for a specific sort of RNA genome. So in theory, it should be very specific. And what we see is generally it is close to 100% specific, but the question is around sensitivity. Again, in theory, it should be sensitive, but there's a lot of factors that affect how that actually plays out in the clinical world. So when you look at evidence around clinical sensitivity, how good is it at picking up the disease in our community? There's not a ton of evidence, but there are some studies, and I'll run through a few of them. The most interesting one is one that came out of China a little while ago, looking at about 1,000 patients. And so what they did is they had patients who were admitted who they thought they were fairly certain that they had COVID, and that was based on sort of symptoms and signs and maybe some testing that had been done. But the big problem here is what's the gold standard, right? What are you going to compare this to? So what they did is they took all of these patients and they put them all through the CT machine, and then they did PCR testing on all of them as well. What they found is when you looked at those results, they found that patients who had a CT had results that were fairly consistent with COVID about 88% of the time. And patients who had PCR testing had results that were consistent with COVID 59% of the time. But the problem is what's the gold standard? Who actually had COVID? So what they said is, let's just say the CT was the gold standard. So if we used everyone who had a CT consistent with COVID, we're going to assume they have COVID. Then the PCR testing was about 71% sensitive in that case. And that's where I think where that number comes from. You often hear it's about 70% sensitive. And that was one of the first tests that kind of talked about that. Now, since then, there's been some other groups that have looked at all the other factors that might affect that. So questions like, where are we going to sample? What's the best site to sample? When's the best time to sample? All those other factors that are likely contributing to a decrease in sensitivity. And so the problem is when we tried to summarize this is the numbers are sort of all over the place. And we saw, some studies would report things like bronchoalveolar lavage as having a 93% sensitivity. Others reported things like throat swabs having a 50% sensitivity. And there's so many limitations with these tests. Again, what time the swab was done. A lot of the studies don't describe how they did the swab, so the actual technique isn't clear, and all these other pieces. So if we had to estimate, anywhere from 50 to 90%. Now, locally in Canada, Alberta has reported a case series of about 30 patients where they were tested positive and then re-swabbed, and they found sensitivities between 80 and 90% with throat or nasopharyngeal swabs. And there's a preprint paper out of Toronto that looks at nasopharyngeal versus sputum and reports sensitivities of 78 to 90%. So the numbers are sort of all over the board, and it's hard to give you an absolute. But the thing that's really interesting with all of this is that your false negative rate really depends on your pretest probability. So what's the chance that these patients even have COVID to begin with? And I did this tool with James. It will be coming out next week. It's really, we chatted a lot about this. How do you estimate a pretest probability? In the clinic, I struggled with that. Because we think everything's COVID, I said my pretest probabilities were very high. So trying to look, step back and say, can we come up with some sort of rational estimate of pretest probability? And so we tried to look at a couple of different situations. So if you look at data around influenza illness, for instance, so in the United States, in the last number of months, the CDC estimates about 50 million cases of influenza. And over that same time, there was an estimate from Johns Hopkins of about 1 million cases of COVID. So it's about a 2% chance of having COVID if you had sort of influenza-like symptoms. So, I mean, could you say that's a pretest probability of 2? Or in Canada, if you look nationwide, our positive testing rate's about 6 to 7%. And I know that's not a great estimate of prevalence, but it suggests that in patients who are presenting with symptoms or who are being tested, often it's less than 10%, the chance that they actually have the disease. So we, if you do some calculations, and the math nerds out there would love this, if you look at a test that's about 100% specific and maybe even worst case 50% sensitive, so taking a worst case, which is probably not, in a patient who has a pretest probability of 10, your risk of false negatives is about 5%. So in the general population with low pretest probability, your risk of false negatives is actually quite low. Now, if you're in a hospital where there's a very high pretest probability, say your pretest probability is 80%, then your risk of a false negative is about 40% in a really low quality test. So it really depends on the pretest probability and the prevalence, which is hard to estimate, but we've tried to come up with some ideas. So I did this with James. I don't know if James wants to pipe in and comment on this at all.
Yeah, so before you comment, let's just put the Jeopardy board up so people, and the next vote will be for the Atlantic provinces. So if they want to chime in and start voting now, James, go ahead. Tell us a little bit what you have to add.
So exactly what Tina said. So there's two scenarios. People who have never tested positive. So if they've never tested positive, Tina was talking about a pretest probability of probably no more than 5%, probably even down to 2% or 1%. In that case, if the test comes back positive, you have COVID. If it comes back negative, even almost regardless of the sensitivity, whether it's 50%, 70%, or 90%, if it comes back negative, almost for sure it's negative. So that's the one scenario. Where we get into troubles with sensitivity is the people who have already tested positive and then you're retesting them because their pretest probability is much higher. And so as Tina said, if in that population, the sensitivity of the test is really important because you can go anywhere from about an 8% false negative up to 40%. So that's where the issue of a bad test comes in. It's not so much in the people where you have very low pretest probability. So that's the key feature. It's just those two different things to think about.
Okay, thanks, James. Back to the Jeopardy board. We're getting votes coming in right now, and it looks like number 5 is the next choice for us, which is the medications that are felt to be risky. And just before you start that, Adrian, I will. People are asking, what is peer? Which is a great question because that's our job. So what is peer? Peer is a group of primary care clinicians made mostly up of family doctors, pharmacists, and we have a nurse on the team. They're spread around the country in provinces like Ontario and Quebec and BC and Manitoba. And what we do is we look at evidence and try and summarize it focused on family physicians, but also other primary care providers. You'll know us from things like Tools for Practice, the podcast, and popular guidelines like the Simplified Lipid Guideline, the Simplified Cannabinoid Guideline, and the Simplified Opioid Use Disorder Guideline. So we do all of that and more, and we try and look at evidence in a primary care focused perspective and bring you the best available evidence that we can find. And none of us, a rule to get into peer is you cannot have taken support from industry. It's a very important thing to minimize our biases. But Adrienne, sorry, back to you, number 5.
No problem. Okay, so this is a very fascinating question, not necessarily because of the evidence, but because of the story that's behind it. So a couple of months ago, when some of the information was coming out that people with diabetes or hypertension or heart disease are at higher risk of mortality from COVID, people started to speculate why that might be. And there was a letter published in Lancet Respiratory Medicine saying that this might be because these people are on ACE inhibitors. And the problem with ACE inhibitors is that they can actually cause upregulation, same with ARBs, of an enzyme called ACE2, which the coronavirus actually needs to enter cells. So that was what started this whole downward spiral, for lack of a better word, with thinking that there are problems. It wasn't based on case reports or anything at the time. It was based purely on speculation about the mechanism of these drugs and why some people are doing more poorly. Had nothing to do with the fact that these people were already maybe a bit more sick with some of their comorbidities. So that was kind of what started this. There wasn't a ton going on in terms of the RAS inhibitors, the renin-aldosterone angiotensin system inhibitors, until recently. And then actually just in the last week, we had 3 really quite well done observational studies published in the New England Journal of Medicine that tried to actually answer this question: are ACE inhibitors and ARBs a problem for people with COVID? Now, these were 3 different studies. One was from Italy, one was from New York City, one was using an international registry. They had slightly different methods. We won't get into some of those details there, but the bottom line is that none of them found an association with ACE inhibitors or ARBs and increased mortality or increased risk of getting a COVID infection. There was a thought that that might happen, but as soon as they tried to adjust for the reasons people are on these medications, the indications for them, their associations completely dissolved. So it was actually very reassuring, especially because the way that some of these studies were designed, if anything, I kind of would expected of it to show that there was an association, and it didn't do that. So for me, these were 3 very reassuring studies that ACE inhibitors and ARBs are probably fine. One of the studies as well actually also looked at NSAIDs and found there's also no risk with taking NSAIDs. So let's move back and talk about what happened with NSAIDs, because this is an even more fascinating story. So that initial paper, that letter that I mentioned, that talked about the theory behind why ACE inhibitors and ARBs are bad, also stated, it was one line, that NSAIDs can also increase upregulation of this ACE2 enzyme. Therefore, NSAIDs are bad. That was it. It was one line in this letter. A week or 2 later, the health minister of France tweeted that we shouldn't be using ibuprofen in patients with COVID because it can worsen things. There was some communication from WHO about maybe we shouldn't use NSAIDs. It caused a lot of confusion, but there really wasn't great evidence for this. However, if you look at the history of what's happening in France, it kind of explains what the health minister did. So back in 2018, the country of France had actually started looking at the relationship between ibuprofen and NSAIDs with some bacterial infections and some complications from bacterial infections. And some of them were quite serious, including hospitalizations and death. So in 2019, they had actually gone and said, you know what? We're going to recommend acetaminophen or paracetamol for most of these types of viral infections, and that if you have to use an NSAID, use it for the lowest effective dose for the shortest amount of time. So France already had a policy for the last year or 2 kind of looking at recommending acetaminophen over ibuprofen. So when the health minister tweeted this, if you take it out of context, it looked very alarming, but the reality is that was actually what France was doing already. We don't have really any good evidence about the problems with NSAIDs in COVID at all. I was reading just another preprint observational study again today saying there is no concern with NSAID use with COVID. There has been one randomized controlled trial that was not in COVID. It was about 7 years ago that people have advocated for saying why we shouldn't use ibuprofen. It was in just plain respiratory tract infections. It was a primary care study. It was a really interesting little study. Overall, most people did fine if they were given ibuprofen or acetaminophen, but one of their secondary outcomes was looking at reconsultation. And more people on ibuprofen had to get reconsultations than acetaminophen. And so people are also using that as an advocacy for why NSAIDs are bad. But there are some issues with that study. It wasn't COVID, and there were some problems that they didn't actually blind or do any allocation concealment to make sure people were randomized to the appropriate groups. So I don't think it's a particularly reliable study. So I kind of look at all this and I think this is a great story in terms of how things have evolved, and maybe some panic and hope and people looking for reasons for things. But when we actually look at the data, there doesn't seem to be any risk of harm from using ACE inhibitors, ARBs, or NSAIDs in people with COVID.
Thanks, Adrian. Brian, can we have the board again? Thank you, Adrian. That was a really good review of ACEs and ARBs. And well, we're having Quebec will be the next province. If you could pass in some votes from Quebec, we'll look at that topic next. But I did want to ask the group: is this the first time we've ever seen a physiologic theory turn out not to be correct? This seems to me as a big shocker.
I feel like we've seen this before.
I think we know the answer.
I think we have an entire talk on this topic.
Yeah, we do. We call it misdirection medicine, misdirection magic. So it's a classic example of how we kind of get distracted by a good story when there's very little research, or actually research to the exact opposite.
Yeah, and the line I think we always use, Mike, is we don't care how it works, we care if it works.
But yeah, exactly.
For clinically important outcomes.
Yeah.
Not changing surrogate markers, stuff like that.
Or what receptor it binds, or anything. Let's just look at whether people do better with or without it, and let's focus on that. And it turns out that that's exactly what Adrian did, and it certainly wasn't any worse. Okay, so it looks like coming in for is number 7. So we'll start from Quebec. So we'll I think that's Mike Colber. Mike, can you jump on number 7 for us?
I could, but I think it's Adrian. I can help out. I've also helped out, but yes.
Oh, is it Adrian? I'm sorry.
Yeah.
Adrian, do you want to go?
Sure, yeah, absolutely. I'll talk about these ones. These ones are great, very different from the NSAID world. So in this case, we're only going to talk about randomized controlled trials. Observational data when you're talking about treatments can be very misleading. So really just going to talk about RCTs. We'll do I can't even say it now, Remdesivir first. There's one published study. It was an industry-supported double-blind placebo-controlled trial of about 200 patients from Wuhan. These were patients who were hospitalized, but not necessarily ventilated. And what they found is that 28-day mortality, there was no difference between people who got Remdesivir or placebo. The duration of mechanical ventilation was a little bit shorter, although it wasn't statistically significant. This was 7 days versus 15 days. And time to clinical improvement was also better, 21 days versus 23. Again, not statistically different. What's fascinating about this, so I mentioned some of these trends, they sound impressive in terms of the difference and just not being statistically different, is that they actually ended this study early before they achieved their proper sample size. And they did that, and this is a quote, because the outbreak was controlled in Wuhan. So unfortunately, I ended the study early, even though there could have been some promising results there. There were more adverse effects leading to medication discontinuation for Remdesivir as well. It was a number needed to harm of about 15. And then things start to get interesting because in the last couple of weeks, we've seen some media releases about Remdesivir. One of them was a media release on interim results from a study, a double-blind placebo-controlled trial of Remdesivir, and again, versus placebo. In this case, they found a statistically significant reduction in time to recovery of 11 days versus 15 days for placebo. They also found a difference in mortality. It wasn't statistically significant, but it was 8% versus about 11.6%. So this is fascinating. This is very promising, but these are interim results. There's a ton of questions we have about these results, and we need to see the full publication. We don't know if there was issues with selective reporting. We don't know how good the randomization was, if there was any kind of statistical manipulation. So some promising stuff, but still way too early to say that this is something we should be using in everyone. And in fact, Remdesivir in Canada right now is only available for people enrolling in clinical trials. So it's not available for compassionate use anymore, which I think it had been for a little while. In terms of other antivirals, so lopinavir, ritonavir, which is Kaletra, we had an open label RCT of about 200 patients, again from Wuhan. And they're randomized to this combination drug or placebo, or for 14 days or usual care, pardon me. Once again, it was not a statistical effect on mortality. It was about 19% versus 25% for usual care. And time to clinical improvement was shorter by about a day. Length of ICU stay was a little bit shorter as well. Once again, though, the enrollment was suspended early, so it might not have been powered to actually find some of these differences. So, for example, in this case now, they stopped enrollment because Remdesivir became available. So they stopped enrolling patients in the study, and we end up with another underpowered study. There are a lot of other studies going on with both Remdesivir and this combination lopinavir-ritonavir that will hopefully not be stopped early and will continue on to actually see how well these medications work. Another antiviral that we looked at was oseltamivir, something that everybody's quite familiar with and comfortable with. But there's actually no RCTs that have been completed so far in COVID-19 with oseltamivir. And we actually couldn't find any RCTs looking at some of our other coronaviral infections either, like SARS or MERS. We couldn't find RCTs on that either. It's a little bit of an issue. So to date, we don't have any good RCT evidence really saying that we have a strong antiviral that works really well, but there's definitely some hope on the horizon with some of these medications. We really need to have full publication of these studies. We need a lot of transparency to know how reliable this evidence will be.
Great, thank you, Adrian. So just I'll ask the group to comment in just a sec, but one of the questions that came in is you're using observational studies, and yeah, we are when it comes to things like diagnosis and harms, and those are acceptable study designs for those questions. The better is still RCTs, but observational studies are acceptable for harms, and that was the questions around ACEs and ARBs and for making the diagnosis. So anyone, I'll just have let people know who are watching that the next vote goes to the Western provinces. That's from Manitoba all the way to BC. So Saskatchewan and Alberta, will probably be giving them 2 rounds at voting because it's a big group. But if you guys can start voting now, that would be awesome. In the meantime, anyone have any comment about Remdesivir? I know Mike looked at a lot of this data as well. So Mike, would you mind just wading in a bit on what you found as well? Or
Sure. Again, I think this is fascinating. Adrian covered it very, very well. The only published study in Remdesivir, it was a moving sample size. They opened it up and said, man, we got a lot of patients. And then they increased their sample size again. And then they came back and said, no, we've controlled COVID and therefore we didn't quite hit it. So there's a bit of manipulation going on there as well. It's very interesting that when the other one stopped because Remdesivir, so the lopinavir-ritonavir, because Remdesivir came on, I think they're from the same area, same hospital, and it's often the same cohort of people that are looking at these questions. So it's very amazing how interconnected all of these studies are. I think one of the most important things coming down the road is exactly like Adrian said, we do need publication to really figure out what's going on, especially with this second study that might have shown a difference in median time to recovery. This was an NIH supported study, multi-country study, but I suspect it was also industry supported, and you have to take it with a grain of salt when you only see part of the picture. The final comment would be the cost of this medication. There's behind the scenes bantering as to what the cost might be, anywhere between $2,000 to $10,000 per treatment. So if you multiply the number of admitted patients in the world by the cost of Remdesivir, this is a $1 billion intervention. So it'd be great to see the literature in full publication before we jump on the Remdesivir bandwagon. I see that Japan has approved it after 3 days of, so the company submitted for approval in Japan. It was approved in 3 days, which seems like a record. I think it's really important to mention to the listeners that approval of a medication for treatment does not mean it works. And I think that we'll see it's going to be approved. Again, in Canada right now, it's only for clinical trials, and I suspect that might change in the very short future. Great.
Thanks, Mike. It looks like the requests most commonly coming in are number 8. So Tina, if you want to wade into asymptomatic frequency and transmission, and I think Mike has a secondary on that as well, but Tina, would you take asymptomatic frequency transmission?
Yeah, sure. This is a really interesting area as well. The question of when are people actually transmitting the virus between each other? So again, some of the data came first from case reports, and so interesting. Yeah, when people say the quality of evidence you're using is not great, it's totally true. We would love to see better quality evidence, but trying to look at the best available evidence. So case reports came out of people who were developing COVID who had not been exposed to symptomatic people. And then a couple of countries did sort of case finding. So in China, they looked at just over 400 cases of COVID transmission. And what they found in that is that about 13% of the cases, it seemed that the secondary patient reported symptoms before the source patient. So it seemed like people were transmitting it before they even developed symptoms. So it was about 13% of the cases in one group, and another cohort out of Singapore. They did contact tracing, and they said about 6% of the cases seemed to occur. They received the COVID from someone who didn't have symptoms yet. And so there's other cases like that. And we looked at this, and Mike will comment on this. When we first looked at this, we thought, oh man, this data is not very strong. There's tons and tons of limitations. And actually, in the tool that we wrote, the limitations section is about as long as the evidence section, recognizing that anytime you have this type of data, there's recall bias, potentially, lots of assumptions, assumptions that exposure to symptomatic patients will trump an asymptomatic exposure, and assumptions that everyone who tests positive for COVID is actually infectious, and all these sorts of things. So there's certainly some limitations, but it sort of fits with some of the experience that we've had. And then there's other groups that have looked at this on a larger scale. And what they found is that when you look at how it spreads through different communities, it seems like the interval between different people catching it can sometimes be about, say, 4 days, whereas mean time to symptom development is 5 days and sometimes longer. So that idea that if you look on a population basis, there is the potential that people can be spreading it before they're actually symptomatic. And so when you do these modeling studies, and we know there's actually lots of jokes about modeling studies, and we've seen tons that have been inaccurate and untrue. But when you look at the modeling studies out of all over the world, and sort of from BC and different parts, they sort of consistently suggest that there has to be some element of asymptomatic transmission, and some of them are estimating that it's up to 60 to 70%. So nobody knows for sure, a pure estimate, but the idea that it's likely occurring. And this fits with viral loads. So studies looking at viral loads suggesting that it's similar in asymptomatic people to symptomatic people, and it's highest right at the sort of beginning of your symptoms. And again, there's assumptions there as well that correlates to transmission. But all of those pieces together sort of suggest that it is potentially occurring. And the interesting piece of this is, if it is occurring, the number of people who are asymptomatic in the community seems to actually be quite large. And so it's hard to estimate, again, because who are you testing? So we want to look at closed populations where they tested an entire population. So examples of that would be the cruise ships, or long-term care facility. There was a good report on Washington, or a town in Italy where they tested the entire town. And in those situations where they tested the whole population, for those who were positive for COVID, about 50% were not symptomatic. And asymptomatic can mean two things. It can mean, one, you have the virus and you never develop symptoms, or two, you have the virus and when you're tested, you don't have symptoms, but you go on to develop that. So that pre-symptomatic. But it does seem that in the population, there's a fair number of people who are at some point are testing positive but have no symptoms and may be transmitting this virus to others.
Sorry. Okay, thanks. That was great, Tina. I'll just let people know that we're still taking your votes, but we do have a couple chosen for the next round. But in the meantime, Mike, I think you worked on this one as well, and you want to just want to make a quick comment or addition to what Tina had contributed.
Sure. So 2 points. Number one is we're not competing with the World Health Organization, but when they early on said that there's no asymptomatic transmission from 30,000 feet, that sure didn't make sense. If there was only symptomatic transmission, you isolate, quarantine the symptomatic people, and this goes away. So we thought there must be something going on, and Tina's did a great review on this. Since we wrote this Tools for Practice, there was a very interesting nursing home study out of the States where an outbreak, and they tested, just like Tina said, they tested every nursing home resident for COVID. Out of the tests that they did, 50% of about 90 residents tested positive. And of those, half of them were asymptomatic at the time. This one, they went and followed them further to figure out whether they developed symptoms or not. And I would assume that my long-term care residents would be more likely to develop symptoms with COVID positivity. Eventually, about 90% of these patients developed symptoms. So again, they were pre-symptomatic at the time of mass testing. But interestingly, and kind of similar to what Tina had mentioned, median time was 4 days later. So again, the group that's going to be, I think, very likely to pick it up, they picked it up. They were 50% asymptomatic at the time, 90% developed symptoms down the road, 4 days, but 4 days after, which is exactly what Tina found, but I thought it might be even earlier in our long-term care residents. And unfortunately, a third of these people died. So again, another really, it just brings it home that at the time of testing, and maybe it's time of determining asymptomatic and pre-symptomatic is important, but it's just highlighting that patients are asymptomatic at the time of testing, and therefore they are contributing to onward spread of the disease.
Okay, thanks, Mike. That was great. The next one we're going to do is number 6, and then we'll start to address all of the ones that we've been coming in. So keep voting, and our team with the CFPC will be monitoring that vote thread, and we'll also be addressing some other questions. Like there was a question here, just quickly, guys, about Remdesivir, and the question is, were they severely ill, moderately ill, or just all hospitalized patients for the Remdesivir study?
So there was a couple of studies. The main one, the published one, they were considered, I don't know if they were considered moderately or severely ill. They were hospitalized. They were not mechanically ventilated. For all the Remdesivir people, oxygen saturations had to be less than 94%. They usually had to have radiographic pneumonia as well in the studies. I don't know, Mike, can you remember anything else?
Yeah, no, there were two study arms very similar. The one that's been published is on the mild to moderate. So the severe with O2 sats less than 94%. And then they're also looking at a mild to moderate arm where, again, admitted radiographic evidence of COVID, but O2 sats greater than 94%. And that one has not been published yet.
Great. Okay, thanks. We'll get to your other questions, but one of the ones we wanted to deal with next, or you've been voting for, is number 6. That's mine. It was actually Nick Dugray's, but as I mentioned, Nick, unfortunately, just to how busy things are in Quebec, couldn't join us today. So the question for number 6 is the use of masks in community effective in preventing viral respiratory infections? So we looked at the evidence for this, and there's, of course, I've heard lots that there's no evidence for wearing masks in the public, and actually there's a lot of evidence. And there are RCTs. They're cluster designed because that's often how you have to do this kind of RCT, so please don't lose faith in it for that. There are 7 systematic reviews that we found, but many of them were combining observational research with randomized control research. They were only using some. They were analyzing strangely by whether or not hand hygiene was also used. And so it just got so that we couldn't really report much on them. They weren't analyzing them the way people would use masks. And there were no RCTs of COVID. That is so important to stress. So what we're doing here is we're looking at the next best thing is viral illness. We tried to look at influenza, but I'll explain the limitations there. There are 12 randomized control trials that have attempted to address the use of community masks in some way or another. One used a large community visiting Saudi Arabia, actually, for the Hajj. And the problem with that one is when you were randomized to wear masks, only 25% of people wore a mask. And those randomized to not wear a mask, 15% of them wore a mask. So it really wasn't a good comparison of wearing or not wearing masks. 2 others that were in the community were done in Michigan at a university setting. And they are actually the ones that mirror what we're hoping to do with having people wear masks in the community. And they randomized university houses to wear a mask every day for a minimum of 5 hours, or quotes most of the day. And compliance was actually quite good. The average use was just north of 5 hours a day. And they compared that to people not wearing masks. And at the end of the study, after 6 weeks, what they found was there was no difference in influenza-like illness or confirmed influenza. And it really didn't matter whether you added in hand hygiene. So some of you might be losing hope, but one of the key things to remember here is that in these studies, the number of people with disease is low. And that's what drives the power of your study. And because of that, these studies are really underpowered, even though they have 1,100 people and 1,300 people almost. So when we looked at the data, Nick Dugray pointed out that this is the best research we're going to get, and these studies are virtually identical and are perfect for pooling. So he performed a meta-analysis of them, which I'll report for him. Confirmed influenza did not differ. It was around 2% whether you wore a mask or not. And again, that is so low, it's underpowered to show anything. But looking at influenza illness, as they define that, is respiratory symptoms plus a fever or chills or aches. And for influenza illness, it was 19% in the mask group versus 25% in the no mask group. That was statistically different. That was, if you like relative numbers, that was a 17% relative reduction in influenza-like illness. And if you like numbers needed to treat, it's a number needed to treat of 15 over 6 weeks. So that is by far the most positive data out there. And surprisingly, no one's actually analyzed the two studies that actually address the key question at hand. There are other studies. There was a community study that looked at households, though, and what it did is it issued masks to everyone in a household. This was poor communities with an average of 5 people living in a 1-bedroom place. And what they did is they said, the moment anyone gets sick, start wearing masks. Everyone wear masks. And what they found was virtually no difference in influenza-like illness, with mask and hand hygiene getting 1.8%, hand hygiene getting 2% and 2.3% for control. And these are the people who aren't initially sick. This is for the rest of the family, how many of them got sick because of the sick member. But if you look at any upper respiratory viral infection, you'll see that masks with hand hygiene, and it was really the mask because hand hygiene didn't make a difference in this case. And don't forget, it's all about compliance in these hand hygiene studies. Most times they wash their hands once more a day tops. But the mask was 12% chance of getting an infection from someone in your house versus a 14%. That's a tiny reduction, but it is a number needed to treat of about 50. This study followed them for a year, so it was trying to catch cold episodes. All the rest, there are 8 other RCTs, and they did something different where they had a patient would come in to be seen in the emergency or medical clinic, and they would say, it looks like you're sick from the flu or what have you, so we're going to send you home with masks. And sometimes they would say, you wear it, you're the sick person. Sometimes they would say, we want your family to wear the mask. And sometimes they would say, we want everyone to wear the mask. These studies come from everywhere: Australia, Germany, France, Thailand, China, Hong Kong, and Saudi Arabia. They range up to 442 sick contacts with over 1,000 family members at home. That is not in one family, by the way. That's spread out over the 440 sick contacts. If you say to the mask people to wear, or you say to the healthy people to wear the mask, or if you say sick people wear a mask, or healthy people wear a mask, or both, it really didn't matter. Nothing was positive in those. They're small studies, so hard to tease out. But remember, by the time someone's showing up in the hospital saying, I'm sick, they might have already passed it on to their family. So making a difference in these cases wasn't as strong. Please remember that these are almost all surgical type masks, the classic medical mask. And if you ask me the level, we have no idea. It's so hard to tell. None of the studies, 12 RCTs, not a single one reported the level of mask used. And it doesn't involve cloth masks, and it doesn't involve COVID, and it doesn't involve any other pandemic time either. So if I was to sum up, I would say that there are 2 small trials that, when pooled together, suggest a benefit. of wearing community masks, and it reduces your risk of infection from about 25% to 19%. As Tina mentioned earlier, your risk of getting COVID isn't that right now, but whatever it's at, it will reduce it by about 17%. That would be our best guess, a relative 17% right now. None of the research examined COVID, and it's just one part of the preventive maneuvers that we can do to reduce our risk of transmission. Great, thanks. Anyone want to comment on that? Because I know we all have looked at this kind of data. Anyone want to make a comment from the team?
I was just going to add, it's become it's a very emotional based medicine thing right now, right? Mm-hmm. I don't know about you guys, but when I'm walking around and I see people with masks, I'm in my head, I'm going, now, are they wearing that mask because they're sick, or are they just very concerned about their health, or are they just nicer people than I am if I'm not wearing a mask? I mean, it's, there's so many features associated with the concept of masks, and it's almost becoming a social thing. I don't know if anyone wants to comment on it, but Mike, I think you did a great job of going over the evidence. We may get to the point in BC where lightening up a lot of things, and I think it may go, we may be, in some places you do have to wear a mask. So it's really often more politically than evidence-based.
Certainly, there's a lot of enthusiasm for it, and I think people are looking for anything that they can do that might reduce their risk of either catching it or causing other people to catch it. And I think, James, with your list, I think all of us would agree that they're looking at you and judging you.
Oh, yeah. No. That's happened my entire life.
I think James brings up a good point about emotional-based medicine, and I think that some of the directors and or public health agencies have actually flip-flopped on this a little bit as well. And I think it's not because the information has changed, but because the emotion, and it's almost like do something, and masks can't be harmful, can they? And I think that's what's driving some of this.
Absolutely. And interestingly enough, about the social impacts, I did notice yesterday that the Saskatchewan Rough Riders have released a Saskatchewan Rough Rider face mask that you can order. So that might change mask uptake a lot among Rider Nation.
That's a full watermelon with just eye holes cut out, I think.
Yeah. So those who don't know, Adrienne has been known to wear a watermelon on her head. So
Proudly.
With pride, with pride. and where she might be from.
I was going to say one of the key. Remember, people have talked about one of the concerns about wearing a mask is that you're always, moving your hands and everything towards that mask. Mm-hmm. But all of these studies that you talk about, they would have been wearing masks and they would have been putting their hands to their face to whatever degree. So it's despite that it had the effect that you're talking about. And I think that's an important distinction as well, because some people are suggesting that it's worse if you wear a mask.
Mm-hmm.
Yeah.
With on off.
Yeah.
Potentially. Yeah.
Yeah. And again, that is based on a great theory that is unproven, like so many of these other things. We can rationalize any direction we want for any argument we want. It's whether or not there is evidence to support it. Let's move on to our next question, because this covers a lot of things. And if we have time, I'll have people comment. One of the questions we're getting is about plasma therapy. So if any of you know anything about that, I'll bring you back to that. But right now, we're still catching up to the long list that you guys have sent us on questions. So let's move on to number 9, if we would. That's serologic testing. And I think that's Mike Colbert.
You bet. And maybe just there's a question in the audience about Remdesivir and the 2 studies that have been released to date, and maybe it wasn't clear. Both of them were in the severe cases. So SAT's less than 94% on both of them. One of the outcomes obviously is mortality. And obviously you want to take the sickest of the sick to see if this works. What I was alluding to is there are other studies very similar being done and completed in China and being completed in the US on mild to moderate, and they have not been published yet. So I hope that clarifies everything. All right, so serology. When I first heard about serology, I thought it was the holy grail prior to the vaccine. And the more I read about it, the more I'm like, boy, I'm not sure if it really has a super role. And I'll try and take you through it. This is going to be a Tools for Practice coming hopefully in the next couple of weeks. Basically, I'm going to break it into a few fold questions and answers. So the first is time frame for antibodies. Do antibodies to COVID behave similarly to other infections? I'm not great at immunology, but I do know that I think IgM comes first and IgG goes second. And IgG is thought to be potentially protective. And that's the plausibility of thinking if you actually had it initially and you have IgG antibodies, therefore I will be protected and not get a future infection if the second wave comes by. So looking at the time frame for antibodies, again, the same limitations, the early information from serology, just like the early information from clinical outcomes came from Wuhan and China. And so I think in the next month or so, we're going to see more data coming out of North America. There were 3 studies that I found published. These are cohorts of people admitted with likely COVID and then confirmed COVID with both PCR, like Tina had said, and or including chest CTs. One of them actually enrolled about 100 patients and just did random tests and not serial tests on the same patient. So I don't think that's very helpful. The other 2 actually had confirmed COVID patients in 85 and 170 patients, and then had multitude of serology testing through their admissions into hospitals. Basically, if I could summarize them, both tests increased at about 1 to 2 weeks. The earliest the IgM happened was about 4 days, but really it wasn't super great until a couple weeks. One of the studies showed that IgM was positive over 90% of cases at day 19 for IgM and about 1 month for IgG. The mean seroconversion times was about 11 days for IgM and about 12 days for IgG, so really didn't separate much. The limitations of these studies, as you're probably aware, is that there was no long-term follow-up. So they followed them up to about a month-ish, but we don't know if the IgG continues to be positive. IgM was waning, meaning the proportion of people that tested positive was waning, but we don't know how long the IgG stayed positive. Another caveat is these studies were qualitative and not quantitative. What proportion? It was a yes. This was just a yes or no. So that's pretty tricky, but I guess it's good to know that IgM happens and IgG does happen a little later and maybe persists, but we just don't know how long it persists. So the next role for serology might be trying to determine the prevalence of the disease in your community. And that's where it might be helpful after the fact to see how many of you people actually had COVID, but were asymptomatic. For this, it's really important to be a specific test that you want to minimize the number that actually test positive when they actually don't have the disease. Probably the biggest study that you'll probably have read about is an unpublished study out of Santa Clara and was done by Stanford. They actually recruited 3,300 patients by Facebook ads, and then they actually ran them through. I think they drove them through, and they did the test. Out of the 3,300, 50 were positive. So if you took an unadjusted rate, that was about 2% of the population. If you adjusted it for socioeconomic status and racial disparities, meaning those are more likely to get it, are the Latin American and or African Americans, and they were underrepresented in responding to this Facebook ad, you would round it up to 3%. So that gives you a baseline, maybe about 2% if we're conservative. So if you looked at Canada, if 2% of our population, if this is true, 2% of our population has COVID or had COVID, we would have 740,000 cases. We currently have 70,000 cases reported if you look at Johns Hopkins coronavirus map. So it's a 10-fold difference. So that might be interesting to determine overall prevalence. Now, I think the kicker is accuracy. And right now there's over 100 and maybe up to 600 companies that are actually trying to get FDA approval and or approval in their local jurisdictions to try and get their tests approved for either point of care testing, stuff like that. When you look at Stanford, the Santa Clara study, they did a pre-study analysis in the lab where they compared to PCR, and they found that sensitivity for those that were known COVID positive PCR, the sensitivity was 70%, but the specificity was 100%. Other studies coming out of Germany, the sensitivity was about 36%, pretty low, and specificity was only about 90%. When you look at, there's a indirect report in the BMJ about an Abbott test. I don't know much more about it. It hasn't been published yet, but they report sensitivities and specificities, so in about the 99% range. If that were to be the case, that might be a useful test to take forward. So I think the million-dollar question, however, is just because you have antibodies, does it really confer immunity to future infections? We don't have any literature on that at this time, and I don't think we're going to get it. I really can't see us reinfecting patients with antibodies to see what happens. I think we're going to get this answer probably after vaccines, and we follow people who have had a vaccine and follow their antibody status and see what happens. But that's kind of where we're at with serology. I thought it was going to be really, really amazing. You know that some of these inaccuracies in these tests, probably an inaccurate test is probably worse than no test at all. And I guess if I could summarize the bottom line, I would say, well, IgM and IgG antibodies may tell individuals recent or past exposure, really, really unsure whether this confers immunity to future infections. And I think the accuracy of the testing and knowing it's very hard to make sense of 600 different tests because I think they're all a little bit different and really requires large validation with large numbers of both infected and non-infected patients.
Great. Thanks, Mike. Just a quick comment. We had a question come in about masks. There is no, you're absolutely right. Masks may prevent also us giving infections to others, but that has never been researched except for the studies of sick people who were exposed way before they wore a mask. But we're going to see if we can cram in one more. James, if you could deal with hydroxychloroquine in a kind of 3 to 4 minute run, that would be awesome.
Yeah, no, it's pretty easy because it's we can go through it pretty quickly. So for those of you, I'm sure, who've been following the news, we all got sensitized to the concept of hydroxychloroquine and azithromycin because on March 21st, Donald Trump tweeted, "Hydroxychloroquine and azithromycin taken together have a real chance to be one of the biggest game changers in the history of medicine." So that sounded pretty good. I don't know if the only thing that I think he got right on there is he actually did pronounce the names of the drugs correctly, which is good. Although he did say them slowly. So that started the entire ball rolling when it came to the whole concept of should this medication be used. And what it primarily started from was a single study. And we did a tools, Adrian and I did a tools for practice on this. And it really came out of a single trial that came out of France by a guy named Gautret. I'm hopefully pronouncing that correctly. And what it was a non-randomized study in 42 patients. And they looked at the number of people who had a negative swab a number of days after, whether they were taking a control, hydroxychloroquine, or the combination. And in that study, they did show that the group that got either hydroxychloroquine or hydroxychloroquine plus azithromycin, a number more were negative than in the control group. Now, we've talked a little bit already about the problem of just the swabs in general and all of the false negatives you can get. But this trial, there's so many limitations to it. It wasn't randomized. They didn't report anything on clinical outcomes. They didn't report anything on adverse effects. And we really, at that time, when we put out this tools for practice, which I think was back in just right at the end of March 30th, we said that without further evidence, hydroxychloroquine is not appropriate for patients with COVID-19. And now, so what I want to do is just very quickly make a summary of what we found since that time. There have been 2 randomized controlled trials, 4 cohorts that are looking at efficacy, 4 cohorts that are looking at QTC intervals, and also a reanalysis of that original trial. And just for the sake of time, I'm going to make it very quick. We really don't know. One cohort looked like it was suggestive of benefit. One looked like it had either no effect or maybe even worse outcomes. The 2 RCTs, one was an RCT of 2 different doses, so we couldn't even figure out if it was actually working. We can't tell because there was no placebo group. One of the most important thing that I think we need to remember, and this is coming out from reasonably good data, is that a lot of these people are now looking at potential adverse events. So what I can tell you is that based on RCT data, the people who take hydroxychloroquine tend to have more adverse events, especially the higher dose patients. One RCT that we have, the adverse events were 30% for hydroxychloroquine in the group that got it, and then in the standard of care, it was 9%. One of the key aspects that's coming out is that there have been 4 cohorts that have looked at QTC interval issues, and this definitely seems to be an issue, especially with high doses. And a number of studies are suggesting that usually cohort studies, is that critical QTC prolongation is occurring in about 10 to 12% of patients. And it can vary depending on the cohort study that you're looking at. And in fact, one person has required in one of these retrospective studies cardioversion probably 2 to 3 or 4% had to stop because of the QTC issues. So I think where we are now is we have virtually no evidence that there's a benefit. We have probably as good as evidence as we're going to get is that there is some harm. And I think right now, exactly the message that we put in our tools for practice is that it really is not appropriate for patients with COVID-19 in primary care. I would suggest I don't believe it's appropriate unless it's under the guise of a clinical trial. And I think that's what a lot of people are saying with regards to that. So that's pretty much where we sit with hydroxychloroquine. And I'm just going out on a limb here. It doesn't sound to me like it's one of the biggest game changers in the history of medicine.
You don't think so, James? That's a big shock.
Call me crazy, but I just don't see it. And again, we've talked a little bit about the emotional context. And, you know, I'm sure you guys have heard about this well, you know, it doesn't hurt if you try. And well, in this case, it does.
Yeah.
And,
often wrong, never in doubt.
Yeah, exactly. Yeah. And so I think in this case, I just, you know, one other caveat, there are more RCTs being done, which I think will more clearly answer the question. And I hope I'm wrong, because boy, oh boy, have we not ever spent a lot of money and put a lot of people on this. And, you know, there's probably literally millions of people who have taken this medication now.
Okay, thanks, James. And sorry we couldn't get to everything and all your questions. We were going to talk about plasma, but I see we're over time. So if you have those questions, you want them addressed, please email us or send them in. Happy to try and get a summary for that. Brian, can we move to the next slide just to wrap up? So this is the bottom line slide. It's obviously very clustered and we don't expect you to read it. I just wanted you to know that it's there for you. If you would like to go to the our CFPC webinar page, we have that for you. So it's all summarized, all 10 topics. Next slide, please, Brian. So don't forget about claiming your credits. They're credits for until the end of day Sunday, and you get 1 credit, which is directly entered for you. You just have to complete a short survey link about evaluating the program and your learning. Next slide, please. These are our upcoming talks. So May 14th, 1 week from today, we'll be doing optimizing care in the elderly and long-term care, and that will be in during the pandemic, and that will be in French. And then May 21 will be another iteration in English, and that one will be regarding the global pandemic, and we'll interestingly have an international panel for that. And the last one, May 28th, that's planned, that's all planned up for you, is caring for vulnerable populations, again in English, and that one has a kind of all-star lineup too, and we'll be giving you further information on that very soon. Next slide, please. Or is that it? No, that is it. So thank you for watching and staying tuned. Don't forget to complete your credits and stay safe, everyone. Have a great day.